Welcome back, everybody. It's Wednesday, April 13th. We're here again, rain, shine, or wind. We're always going to be here. Before we get started, Gary, I want you to introduce your new partner.
So we thought for Dr. Fauci, we want him to have his own pet. So thanks to Elaine McCann, we have our own coronavirus pet. This is we call this a Fauci dog, perhaps. So thanks, Elaine, for thinking of us. We appreciate all your help and all your support.
And we're boosted.
And we're boosted.
So not to worry. Great. All right. There is some movement since our last presentation here, so let's start off with some of the epidemiology. This first slide we're showing you is tracking symptomatic patients in the Sutter Bay Area footprint. So we're now seeing clear evidence that there's an uptick in the positive testing that's going on. You can see it's significant. We don't know how high it's going to go. But the interesting thing is on the next page I'm going to show you is Sonoma County. And Sonoma County does not show an uptick in cases yet. And I'm not sure why that is the case. Maybe we're just better vaccinated than the rest of the Bay. Maybe they're not seeking out care. And that brings us to the point where these charts are going to become less and less reliable in the future because so many people are testing at home. We had a positive case in my household. We didn't call public health. We just dealt with it. It was mild, got over it, and went on. So these are going to become less and less useful. Would that be the case?
Well, it's going to be less impactful from a public health standpoint.
Yeah.
In other words, the ER is going to be doing cases. They'll be doing testing. And so we'll have some idea of how many ER patients get admitted, how many get sent home, and what is the prevalence of testing in the ER. Yeah. But you're right, people getting tested at home, those positive antigen tests are not counted. Right. They're never reported to public health. Right. So a country like Korea is going to look terrible because all their testing comes to the government, they're capturing it all. Someone like the United States in certain areas, their testing at home is not reported and you miss those captures. So what's going to be important is that we're going to see testing go up. It's going to be a fraction of the positive cases, right, and it's going to be all outpatient. So right now we have one patient in the hospital. Right. That's all for COVID. And it kind of represents that we're moving into much more of a mild illness, yeah, and that our hospitalization rates may not track up with our case positivity.
So these charts, that little uptick is directionally correct, but the magnitude may not be relevant.
Right, so we don't, okay, yeah, that's a good way to put it.
So while we're on the topic of home testing, I wanted everybody to be aware for your personal use, but also for your patients, that there are opportunities to get free home tests. And the next slide shows you that the United States government is giving us, and these come through the postal system. You can go to covid.gov, or you can just put in United States, USPS, United States Postal Service COVID test, and they will be delivered to your home. I know we've done this. You can get up to 8 free tests per household. And then for those of us in SMGR, the next slide shows that you can get free testing from our health insurance Aetna. So the slide shows you what you see when you sign in. This is a federal law now. So our health insurance Aetna will supply you with up to 8 free tests per member. So if you and your spouse are on the same insurance, you can get 16 free tests. And the way it works, Aetna is owned by CVS, or maybe it's the other way around, I can't remember, but they're the same company. So the way it works, the easiest way is you go online and fill out some forms and you pop into the CVS pharmacy and pick up your free test. The federal law also says that if you go out and buy tests, then Aetna is required to reimburse you. So there's software and forms on here to allow you to request reimbursement. So there's free testing out there, and this is just going to magnify what the process we just talked about. So Gary, I'm going to take a step back and look at where we've been over the last 2 years, because obviously a lot's changed. 2 years ago there was this virus. We didn't know much about it. We were fearful. People were getting sick. We effectively closed our clinics and quarantined individuals. And then along came ample testing, along came vaccines, along came treatments. And now we're having different conversations. We're talking about people getting it, like in my household. Yeah, they were sick for a bit and got over it, and life goes on. It's different. We're at a different place. So I'm not sure pandemic is the right word anymore, or where are we at?
Well, 2 years ago it was a novel pandemic, okay, and it was spreading in epidemic proportions. And it really devastated a number of countries. What India went through with the Delta strain was amazing. But now we've become an endemic infection. And so in this endemic portion, the virus is adjusting more to each of us. That's why we're seeing variants. That's why some virus recombinates and mixes with another COVID-19 virus. It's because the virus is becoming much more able to pass back and forth in the human host. So it's no longer becoming as novel. And we're moving from the pandemic, from a novel strain into an endemic virus like we do with the flu season every year. And I think that our death rates and hospital rates are going to show that less and less will people get hospitalized. As a practicing physician, I think about two cohorts of patients: those that are unvaccinated and those that are vaccinated. In the vaccinated cohort, I worry about those who are not responding to vaccine because they're immunosuppressed. But I think about how I approach those patients very differently. And I think the NIH does too. So one slide I want to show is kind of how we're doing in Sonoma County. You kind of mentioned this, why are our cases lower?
Yeah.
Is it home testing, is it mild testing, or do we have vaccine or herd immunity? So in Sonoma County, as of yesterday, 83.3% of our population received 1 dose of vaccine. 77% have received 2 doses of vaccine. And if you're unvaccinated, according to Sonoma County data, if you're unvaccinated, you're almost 3 times more likely to become ill with COVID. You're 16 times likely to be hospitalized, and you're 11 times more likely to die. And that's all across the board in different age groups. So if 77% of people have received 2 doses, that means that 23% of people haven't received their full vaccine. So of that 23%, maybe half of them, let's say, as a guesstimation, have some natural immunity behind 1 dose or no doses. And so what's the vulnerability of our population? Is it 10% of our population, which is 36,000 people? Is it 10% of our population is vulnerable to a severe infection? So if I'm in the ER, the first question I ask when someone comes in with a respiratory illness, are you vaccinated or not?
Yeah.
With the flu, it wasn't as big of a deal because the vaccines were not as good with the flu. But with COVID, it's all the difference in the world. So that's a really important thing. Okay. Now we have this BA2 variant, right? Okay. So the Omicron strain has an ancestral strain, a BA1, a BA1.1, which is a sublineage of the subvariant, and then a BA2 and a BA3. So BA2 is becoming much more prominent. It's already seeing an uptick of cases in the northeast of the country. And I'll show you a slide here. This is an interesting slide from the CDC. This kind of shows how the variants have changed over time in the US. And you can see I've highlighted in a little red circle how high the BA2 variant is. And it's clearly becoming much more predominant in parts of the country. But what about in the US overall? How is that spread? Now to the right, I added a table here, and I'll highlight for you in blue, that represents the BA1.1 subvariant. So this is more of an ancestral strain, where 73% of the strains in the US are still BA1, and then 11.6% are BA2. So BA2 is gaining some foot in parts of the country. It's 55% prevalent. In California, we haven't seen that yet. So we're still kind of at this low point, but we should expect a lot of community rise in BA2, and I think they're going to be very mild infections. I don't think our hospitals are going to get swamped, except we're going to see the unvaccinated come in. And a couple things about the BA2 that I heard on the CDC call is BA1 and BA2 seem to be similar severity. So BA2 is not more severe than BA1. So again, they're both mild illnesses for those that are vaccinated. BA2 strain is 30% more contagious than BA1, which is why it's becoming predominant. It has more viral fitness. But in perspective, when the Delta strain was prevalent and pretty severe, and then the Omicron strain came behind it, the Omicron strain was 5 times more contagious, 500% more contagious. So the BA2 to BA1 is 30%, but it's not twice or 3 times as 5 times. So that's important. And then there's also some data from the CDC that says that if you've been infected with BA1 and you get BA2, you actually bump your immunity. If you've been vaccinated and then you get infected with BA1 or BA2, you bump your immunity to give you cross immunity against other variants. So having a mild infection is not a bad thing. It actually is somewhat adaptive to your immune response.
Good. Well, let's talk about treatment, because I think that's the phase we're at in this pandemic, and then for most practicing physicians, it's really going to come down to identifying those who need treatment and calling your pharmacy and getting appropriate treatment. That's the vast majority. Because I'm talking about the people that are not hospitalized. So what's new and where are we at? Yeah,
the treatment regimens are very different if you're in the hospital versus in the clinic. I mean, they're entirely different. It's amazing. If you need oxygen, that's the splitting point for whether someone gets treated with remdesivir in the hospital and steroids and everything else versus the outpatient stuff. So as of April 5th, the FDA sent out an emergency update that sotrovimab, which was kind of the driving monoclonal antibody for outpatient treatment, sotrovimab loses most of its activity against the BA.2 variant, and so it's no longer recommended. So I put it in a little box here. What are our outpatient treatment options, anticipating the BA.2 variant will become much more prevalent? So bamlanivimab is the new monoclonal antibody on the block, so that's going to replace sotrovimab. We do have that in our pharmacy. This will mainly be given as an IV dose ×1 in the ER. So this is patients who come in, but they don't need to be hospitalized, they don't need oxygen. That's still going to probably be more in the ER. And then in the outpatient setting, Paxlovid and molnupiravir. And then I put down here from the NIH, you can still consider remdesivir 3 days IV therapy as an outpatient treatment if you're set up for that operationally. But all of the treatments are really best in the first 5 days of symptoms, not 5 days of diagnosis, 5 days of symptoms. Earlier is better. If it's 1 and 2 days, you're going to get a better bump from that. And then I put here at the bottom, Evusheld, which is 2 monoclonal antibodies. It's not a treatment dose. It's a pre-exposure prophylaxis for people who haven't responded to vaccination, especially the immunosuppressed. So I put it down there as a different color, so it's not as a category for treatment, it's a category for prevention.
Okay, so really for our outpatient clinicians, it's number 2 and 3 on there are options.
Right, yeah, the Paxlovid with a lot of drug interactions, and then the molnupiravir, which is a little less efficacious, but still very good. And it's, again, a 5-day treatment within 5 days of symptoms.
Okay.
Now, I added the slide here. This is what the NIH says, and this goes out to Dr. Hecky, who asked the question, hey, can you just give us a little bit of an update on when do we think about treatment? Who do we think about treatment? So on the right is this tiering group from the NIH, tier 1, 2, 3, and 4, and it's kind of confusing. And if you read it, it makes sense when you read it, but it's hard to keep it in your head. So I put here as a box, kind of how I approach it. I think about outpatient treatment in 4 groups. If you're immunosuppressed, vaccine or not, I wouldn't even check an antibody level, I would treat you. If you're within 5 days of symptoms, I would give you Paxlovid. If you didn't have drug interactions, and I would give you molnupiravir if you did.
Okay.
So immunosuppressed, I really worry about them. I also worry about anyone who's unvaccinated. We've had people as young as in their 30s die in the hospital of COVID, pneumonia, and ARDS because they're unvaccinated. So I would say anyone over 40 and anyone at any age with comorbidities. So a 25-year-old with type 1 diabetes, a 35-year-old with bad asthma, I would think about that person if they're unvaccinated. Now, what if you're vaccinated but not boosted? With the BA.2 variant, I would say over the age of 50 or anyone with comorbidities. What if you're vaccinated and boosted? Anyone over the age of 70, I think as you get a little bit more frail and your immune system doesn't have the same kick and the same memory. Anyone who's pregnant, vaccinated or not, or anyone with comorbidities, vaccinated, boosted, and significant comorbidities. It's different if someone has, think about hypothyroidism that's well treated. Well, that's really not a comorbidity for illness. But if you have a patient who's going on dialysis, if you have a type 1 diabetic or a type 2 diabetic who's not in good control, someone with cardiomyopathy, I think about those patients with significant comorbidity.
What about hypertension?
General hypertension, well controlled, I don't really consider that as much of an issue as I would obesity. So obesity seems to be a real driver of disease severity than a controlled hypertensive patient.
Okay.
Yeah. And if you have any questions about that in the clinic, reach out to me, call me, text me. I don't mind helping you determine who's a good candidate or not for therapy. But my personal take is, if we have drug available, I would be rather liberal about it.
Yeah. The comorbidity seems to be the more difficult one. It's a kind of a loose definition.
That's right.
But your point is well taken. And if the drug is available, why not use it? And are we seeing any shortages of the oral medications?
The Paxlovid and the molnupiravir are becoming much more available, and so I'm not hearing about pharmacies running out of them as much. I think most docs, it's a bit of a headache to think about all the drug interactions with Paxlovid, and that's kind of somewhat of a intellectual barrier for prescribing it. But if you're not sure about that, pull the trigger on molnupiravir. We have 5 times, 10 times more molnupiravir in the pharmacies than we do Paxlovid.
You'd like to think that a pharmacy would pick up on the interactions, but that's assuming they get all the drugs at one pharmacy, so it's not particularly reliable.
Right, outside of integrated care model, it does break down a little bit. You're right. Yeah.
Great. Let me just spend a few minutes on the separate category of medication. This is what I talked about of the Evusheld. All right, and this, remember, is for pre-exposure prophylaxis. Is a different category altogether. This, what I've presented to you here, is information that you have already received. You got this an email on Monday from SMGR admin, if you want to look for it. And this was put out by Dr. Kanan, and much more detail I'm presenting here. So you all have this information along with some great patient handouts that explain it to your patients very well. But just remember, this is another monoclonal antibody. It is given in our infusion center, and the patients who qualify down below are moderate or severely immunocompromised, contraindication to COVID-19, which is not to be confused with somebody who refuses to get the vaccine. And then it's got age 12 and no active exposures or active cases. And then the second slide just goes into the process of how you would refer them. So it says in the middle there, just send us, if you have a patient who qualifies, send a staff message to the pharmacy pool right there, and they'll take over and help you out with that. So kudos to you, Dr. Kanan, for setting up that process. I know it was a lot of work, but this is now available and accessible. And many of the people are already under his domain in oncology, but you might have some patients that pop into your offices who might be available for this.
Yeah.
Good. So the last thing, Gary, is some new guidelines came out today from Sutter, which is updating our return to work issues.
Yeah, this was a note to share from Sutter. Super easy because we're a vaccinated cohort of workers, but you might want to use this. This comes from the CDC, so you might want to extrapolate this to people in the community as well. And I'll just go through it just one by one real quick. In the first tier are people who are boosted or vaccinated, but not booster eligible. So if you have asymptomatic infection or a very mild infection and you're boosted, you only need to be home for 5 days, and that's most of us. In the middle area, if you're vaccinated or those who are vaccinated and booster eligible but have not received their booster dose, and you have a mild illness or an asymptomatic illness, you gotta be home for 7 days. Okay. And the lower one is probably not gonna be that very common, where people are moderately ill, regardless of vaccine status, moderately ill, and it's kind of defined there, stay home for 10 days. So this just came out this morning. I thought it'd be good to kind of put it out there for everyone, because what's gonna happen is we're gonna see more community spread. A lot of us are going to get just simple colds. Yep. You're going to get tested. Sometimes it's going to be COVID, sometimes it's not, because when you're vaccinated. And if you're COVID positive, this is exactly what you follow.
So really, we're down, with our knowledge now, 5 days at home, isolated, as long as you're asymptomatic. And a lot of people, we've been through this with a number of our clinicians, and have made provisions to do video visits from home if they're feeling well, instead of taking ADL. We're using that time to see patients. So.
And it's 5 days from symptom onset, not 5 days from testing. So there's a little bit of a grace period right there. You get symptoms, you get tests a couple days later, you're on day 3 of your illness, you're only gonna be home for 2 days.
Yeah, good. Okay. Last thing I want to mention is, recall we do have CME available to you for watching these videos. We will continue to send out the CME links by text and by email after the second video of the month. We tend to do 2 videos each month. After the second video, you'll be getting that. Feel free to use that. I understand that not a lot of people are claiming CME, but it's free. If you're watching, go for it. So thanks for watching today. Hope this is helpful.